Well, David's taken the quote that both Imogen and I have got as well. So thanks, David, and some other definitions that I was going to give you. I'd like to talk about three things with you today. First of all, goal-concordant care in the intensive care unit, but in particular with patients with life-limiting illness, and what patients actually think is important at the end of life, and how do we get that information from them. The second thing is that goal-concordant care is quality care, and this is no more relevant than at the end of life. And the flip side of that is that discordant care is a medical error. And finally, I'll talk about our journey at Barwon Health to try and get a process of care for goal-concordant care or values-based care for patients with life-limiting illness in the intensive care. So what is goal-concordant care? This is an Americanism. I'm using it because if you do any literature searches on it, this is what you'll find. Goal-concordant care is care that is concordant or aligns with the values, goals, preferences and outcomes of the patient. Darren Hayland and Terry Freed have written quite a bit on this, and there's some interesting findings from their literatures. One of the things that they've found is that patients or people with a life-limiting illness in particular would rather talk about outcomes or preferences or values. So I never want to end up in a nursing home. If I'm not able to toilet myself or wipe my own bum, I don't want to, end up at that point. Rather than, do you want us to jump on your chest? Would you like to be resuscitated? They'd rather talk about these outcomes of what it means for them to live well. Freed did an interesting study where she talked to people about the burden for them on their specific context, and found that a majority of people would prefer quality over quantity of life. And certainly Charlie Cork and I have done a study that found that less than 1%, I'm terrible with the whole transition animation thing, value longevity over other values such as independence and dignity. So good clinical care or quality care, and this is debatable but I don't want to go into it, is around having good technical skills, certainly good communication skills, and a process to implement these. I'm going to talk about two stories from my own life that show two opposite goals that patients or the relatives had, but both have bad outcomes for discordant care. I'm going to let you decide if it's one of these three or a mixture of all. So the first story is a friend of ours whose father in his mid-70s had a new diagnosis of bowel cancer. This friend, who's a very senior ED physician, was called to the emergency department where he and his brother, who is another specialist, met. His father lacked capacity, he was confused, and had a bowel obstruction as a result of his cancer. They were told that his father was going down a palliative, they were going to treat him palliatively, that he wasn't for resuscitation, and of course nobody had had a chance to talk about this. It was a new diagnosis. So they jumped to the fight mode and said, just hold on here, we need to talk to somebody. After a year or so, their father did die as a result of his bowel cancer, but the memories that the family are left with are particularly around that event in the emergency department. The next story is a little more personal. This is my father-in-law, Bill. Bill was a man who died well into his 80s after a long battle with dementia, and he was quite demented towards the end. He was a very dignified man, an old GP who used to do the Times cryptic crossword in his head before he wrote it down every morning, and he got it right every morning too. He lived at home with his wife of 55 years up until the final fall that put him into hospital. After 10 days of us fighting off neurosurgeons and neurosurgical registrars because he had an extradural bleed from the fall, nurses wanting to do CPR and saying we will do it if he has a cardiac arrest, and people wanting to give antibiotics for chest infections, where all we wanted was comfort care from day one, because the only place he was going was a nursing home if something happened. He went into urinary retention. My final memories of Bill are that he thought he was being sexually interfered with when 5 different people tried to put in an indwelling catheter. Now, we finally got a palliative care physician to see him, but they're the memories I'm left with of this beautiful, dignified man. One thing that all these stories have in common is the grief that's been left behind. And grief's bad enough, let alone when we make it worse. You can argue, was it the technical skills, communication skills, or the process in all of these cases? But there's no doubt there was goal-discordant care in all of these cases. So I'd like to ask all of you, I'd like a show of hands for people that have had an experience of a good death, either professionally or personally. Great, good. Show of hands if you've had experience professionally or personally of a bad death. Leave your hand up if you think that matters. Does this matter? Yeah, good, because so does our society. Books by Charlie, Ken Hillman, Atul Gawande, they're all very, very popular at the moment. Certainly things like the inquiry into end of life tell us that this is important to the people we're caring for. Discordant care is a medical error. Now, I've used the definition from To Err is Human from the Institute of Medicine. And among other things, they say that a medical error can be an act of commission or omission. And I would suggest that we are practising omission when we don't talk to patients about what's important for them, and potentially commission when we're giving care they don't want, as is the case with Bill. This book was the Institute of Medicine's publication after To Err is Human, and it talks about 7 processes for ensuring an organisation practices quality care. A common theme in this is patient-centred care, and they talk specifically about shared decision-making for patients with what they call serious illness or a life-limiting illness. So in order for us to find out what's important to people, we have to talk to them. And we have to discover what is important to patients towards the end of life. And we're starting to see this. To do that, we have to teach communication skills, because as David said, we know that we're actually not that great at that. And people are starting to publish more about this as well. But not only do we have to teach communication skills, we also have to have processes in place in our units to make sure that we are honouring these values that people identify, that we are practising goal-concordant care. And this was from the New England Journal around May of this year, this article. So this is something where White and Angus have actually published about a process of care looking at this sort of thing. And there are other things. This is a great article. I strongly recommend this one as well, talking about goal-concordant care. And this is another one. So what is shared decision-making? My slides aren't as jazzy as David's, but I agree we use the menu option too often, and that's this informed. So Charles et al. Are really the ones that have nailed what is shared decision-making. They say that decision-making in health is a 3-step process: information transfer, deliberation, and then a decision based on that deliberation. Shared decision-making is when there is a 2-way discussion about what are the options, including treatment options, what are the issues from us based on our experience and the evidence, but talking to the patients or their relatives about what does it mean for them to live well? Where is their line in the sand? That's true shared decision-making, and it's done together. And I would argue that we are ethically obliged to jump in that decision with them and not be this passive provider of information. Our journey at Barwon Health has been interesting. So we do run a program about iValidate called iValidate, which is around this, and I'll talk more about that. God, I hope that's not my phone. And we've done a few things along the way. So this line is the documentation of values, patient values, and this line is the completion of the goals of management form. And we did actually change our goals of management form. We've gone away from the tick box form, which came from Tasmania originally, and we've gone to where people actually have to document patient values, medical advice based on those values, and the consensus, who's agreed, who's been told. Oh, bugger. So we are improving. Interestingly, this is where we educated the nurses, this one here. So it's a whole unit process now. And we put the form, we're fully electronic in ICU at Bowen Health, so we put the form into Slick. And we're gradually increasing our documentation of values and evidence of shared decision making. So what is iValidate? iValidate is a 4-step process to teach shared decision making. To start it off with just junior medical staff, now it's nurses, physios, social worker. The first step is to identify the patients, and we have a validated tool that does that. And then skills to initiate the discussion, because from the evidence we know that this is the area that they fall down mostly on and can take the most time. If you get this right, you'll be efficient in time and outcomes. What information to gather? So this is important. In a nutshell, where is their line in the sand? What do they value most? What are they scared of? Often what they're scared of is what you think is about to happen. So it's good if you can get that out nice and early. Then to provide information, advice or recommendations based on what they've told you. And that's true shared decision making. Make sure you have consensus, and importantly, make sure you and the patient or relatives leave that conversation knowing that you've both talked about the same thing. And that's that tell-back. We use the Calgary-Cambridge framework for teaching communication skills, a very, very well validated model of teaching communication skills to health professionals. Next, though, we had to make sure that as much as we were happy about our education, and we were we actually doing this in the ICU? Because we know from the knowledge to action literature that education only affects 10% of change in the clinical setting. So what we did next was we spoke to the nurses. Now this is a word cloud. The bolder the word, the more often it came up in the interviews. We spoke to our senior nurses who had all done iValidate just to make sure that they were getting the right message, and they were. They realised it was about patient values, it was about conversations, but they still weren't documenting the values like we'd hoped they would. Next, we did a process mapping exercise with all staff in the ICU, allied health, medical, nursing, and again, it seemed important. We had 4 themes come from this, and I'm sorry you can't see this very well, but this is our process of care document that we are doing now. We're beginning from our process mapping exercise. The 4 themes that came out was that they wanted a clear process. They didn't feel there was a clear process, how am I going, for values-based care and concordant values-based care. That the junior medical staff, there was inconsistency in quality and documentation of values-based discussions, and that they wanted some sort of mentorship and quality control for the junior medical staff, as well as the consultant staff and the nursing staff as well. And as I said, our physio and social worker are also involved. And that we have some sort of control of what's happening outside of ICU. Now the steps are patient identification, that there's a values discussion, so who should have these discussions, that there's a discussion, that there's documentation of that discussion, and there's implementation of what are the values of the patient. And then what do we do about transfer? So I'd like to end with a good story about death. This is our little dog Hagrid, who we had for 17 years. So he grew up with my children, And this little fella taught me a lot about what a good death looks like. Hagrid had multiple myeloma and CCF, and we knew his last days were coming, and we'd said, okay, when Hagrid doesn't eat, no longer wants to go for a walk and isn't really interested in things, we know the time's come. So we had our outcomes. I rang my adult children who are all here in Melbourne at university. We all came home, went to the vet together, and as he got the green dream, he was surrounded by the faces that loved him, and it was very gentle. Thank you.